on this very distressing symptom and very common, which is quite often neglected. So let's see a little bit about the fact file. We all know there is a presence of painful cramps of uterine origin, and we know that it's one of the most common causes of pelvic pain and menstrual disorder. In fact, you could say that this is the leading cause of gynecological morbidity in women across the reproductive age group. Yes, in adolescence, probably along with the irregular cycles, the frightful realization that the periods are painful, that is an important problem. WHO has estimated that dysmenorrhea is the most common and important cause of chronic pelvic pain. And if you're looking at the prevalences, between 45 to 93% of women of reproductive age group have pain. But mind you, every pain may not be severe. It's about 3 to 33%, which may be really very severe and may be incapacitating and may come at various days, first day, second day, third day, as a result of which those poor young kids report a loss from their school or if they're going to junior college. So, quick recap about the pathogenesis. We all understand that primary dysmenorrhea is, we don't know the cause, there's no organic cause underlying. But secondary dysmenorrhea usually has some kind of an underlying pelvic pathology, and majority of the times you know that the responsible cause is the prostaglandins. We blame our pains to the PGF2 alpha, and this results not just in the pain factor, but because of that contraction and concluding the the consistent increased tone, that probably contracts the uterus, and that continuous colicky pain is there. Majority of the studies have shown that women with dysmenorrhea have got higher levels of prostaglandins, and probably in the first 2 to 3 days it's at the peak. And we all again know that prostaglandin production is controlled by progesterone. So when the progesterone levels drop immediately prior to menstruation, that's the time the prostaglandins start increasing. So it's related to the progesterone levels. And majority of the times we've also noticed that dysmenorrhea occurs with ovulatory cycles. There may be causes of pain during menstruation, but that severe pain is typically with the ovulatory cycles. And there are other factors which do play a role in perception of pain, and it may not always depend on the endocrines. So this, I think we all are familiar with this cycle, but we understand that arachidonic acid cascade particularly leads to the production of the PGG2, the PGH2, and finally PGF2 alpha and PGE2. And F2 alpha is the one which initiates those contractions, vasoconstriction, hypersensitization of pain nerve fibers, and ultimately pain. And because the increase of PGs is there, they cause more of endometrial sloughing, and this again, it's like a vicious cycle, hypercontractility and more of period pain that just goes on and on. What exactly happens? Don't we all know? Of course, the quality of life is affected. And when you're looking at younger kids, obviously, this loss of activities, not just from school, maybe the gyms or whatever physical activities they are doing, the pain, it creates a kind of a fear complex. So they don't want to go out in those days. Sleep quality gets affected, poorer mood, negative body image, and this can, if it is correlated, overall cause a problem, and the child may perceive this, that this is going to continue for life, and this could be an important cause of chronic pelvic pain. And of course it does affect the CNS, and eventually even a small amount of pain can affect the sensory nerve fibers, as a result of which the sensitivity or hyperesthesia to the pain increases. And of course these are the standard causes, but there could be other genetic and endocrine causes. And we all know that if the mother or the sisters had dysmenorrhea, invariably that particular girl is going to have it. What all then contributes to the dysmenorrhea? Obviously, there's a heavy period pain, big clots passing out, longer duration of the pain, the earlier onset of pain, all these contribute. And it is generally perceived that once a woman delivers, that pain is going to dissipate. This is a myth in certain cases, but it is also perceived that as you're growing older, so many a times the mothers are telling the daughters, don't worry, as you become 17, 18, this pain is going to go. So they don't allow that little girl to get adequate pain relief when there are enough pain relieving factors available. Causes of secondary dysmenorrhea, I think endometriosis is something that we are now seeing it much more frequently. We all know what it is, but it presents as dysmenorrhea. Of course, there are many a times when there is a grade 4 endometriosis and there is no dysmenorrhea at all, but most of the time in the minimal endometriosis there is a significant amount of dysmenorrhea. And sometimes when the young girls are given some kind of a medical therapy, if they're not responding to it, one should think of endometriosis. And initially, there were the days when we used to first of all go and scope. But today, when you have better diagnostic modalities, better imaging facilities, better access to MRI, probably you know a lot more about endometriosis than we did about 10 years ago. What about adenomyosis? Generally, adenomyosis is thought to be a disease of the reproductive age group beyond 25 or 30 years. But of recent times, you've been seeing young, nully gravid women having severe pain, excruciating pain, and that's because of an adenomyoma sitting there. Probably increased age of marriage, but when you're talking of young girls, you don't generally see adenomyosis at a very young age. But again, there have been case reports, and even in my own practice, I've seen 17-year-old girl having an adenomyotic uterus, and there it's not just the pain, it's the feeling of heaviness, a big stone kept in the pelvis, that kind of a feeling that these girls talk about. And other causes, of course, there are obstructive Mullerian malformations, cervical stenosis, big ovarian cysts, uterine polyps. Usually they cause discharge, and then if they start getting bigger, they might cause pain, particularly during menstruation. Uterine myomas, PIDs. PID is not so common if the girls are not sexually active, unless they've had tuberculosis in the past. But now, because you're looking at the earlier age at sexual intercourse, you're finding the incidence of PID going higher, and that again contributes to the dysmenorrhea and of course pelvic adhesions which arise from that. So how do you diagnose this? Fairly simple. A focused history, physical examination. Usually you're able to diagnose it, the onset, when did it start, how long does it last. Typical, the pain description related to the periods, radiating to the back, to the front, and can also affect maturation during the period time. Usually if you're looking at the girl as a physical, the physical examination is usually normal. But when you're looking at symptoms like nausea, vomiting, particularly in the premenstrual phase, and then there is fatigue, there is insomnia, all these sort of confirm the diagnosis of a congestive and spasmodic dysmenorrhea. And you may not use ultrasound, but then it's always advisable to just have an ultrasound and rule out the other causes. So, how do you treat? I think most important for young children is counseling and reassurance of the girl and her mother or her sister who's accompanying her. We always talk of standard techniques like a hot water bag or a weight bag or an ice pack, and the girl is usually told to take maybe a single tablet and analgesic. But many a times the mothers tell their kids, don't take anything, it'll be addictive. Even educated office going moms telling their daughters, don't take a tablet, just take a hot water bag, you'll be fine. But what we should as clinicians do is ensure that there is no loss of school activities. And if she's responding to the standard NSAIDs, probably aim of our treatment is discomfort should be relieved, and this girl should at least take it for 3 to 4 periods for us to know whether she is getting relief from that or not. And we all know the action, it blocks the complete cyclooxygenase pathway and reduces the prostaglandins. What about the low dose hormones? In younger kids, we don't use the word oral contraceptives. Like for PCOS, when we are treating them, we call it as a low dose combined oral pills. We don't say OCs. So these obviously they suppress the ovulation, they don't cause any endometrial proliferation. Apart from regularization of the cycles, there is a significant relief from dysmenorrhea, significant relief from the premenstrual problems, provided you've used the correct combination of the progesterone. And many a times, they, if there is an underlying endometriosis, that would also respond to these COCs. So now comes the role of, is there anything different that we didn't think of, or did we know it and we didn't really put it to practice? And that is the role of progesterone in managing. Progesterone plays a very important role in dysmenorrhea. Treatment with progesterone causes relief of pain, but then why haven't we been using it for long? I'll just give you a quick recap over the mechanisms of action. It exerts its effect through a decrease in the rate of prostaglandin synthesis. I've mentioned this before, and this rate is shown to be inversely proportional to the level of the progesterone. And the estrogen to progesterone ratio in the myometrium also plays a very important role because it plays as a luteal phase effect. Antitetanic effect reduces the uterine tetany, the contractions, and allows the pain to come down. So the pain which is occurring in the ovulatory cycles, again here, the progesterone has been shown to affect both the synthesis of the prostaglandins and binding to the receptors, and that's how it reduces the pain. So then let's see, amongst the progesterones, if they have a beneficial role. Has dydrogesterone got a role to play, and is there any beneficial role? Well, the clinical efficacy of dydrogesterone in the treatment of dysmenorrhea was assessed in various studies, six placebo controlled trials, about 423 patients, and there was also supportive data coming from a large number of uncontrolled studies. And what was assessed was the decrease and the incidence of the symptoms by using cards. Like you have menstrual charts, you also have diaries where they can mention the number of days the patient had pain, the amount of days she had relief, and how much was the relief. So some of these studies have also assessed the decrease in the use of analgesics because of use of progesterone, and what were the number of days that the girl actually missed school. So at that time when these studies was done, there was no validated questionnaire available, but there were some severity symptoms which were assessed. And let's have a look at these cycles. These were placebo-controlled studies in women done right way back in 65, and the latest study was done by Sultan in 85. And here again, if you see the left-hand side, dydrogesterone with the success rate, analgesics on the other side, and placebo success rate compared with the analgesics. And in both these columns, you'll clearly notice that with the dydrogesterone, that is a progesterone, there was a significant release of pain right in the 65s to the latest studies in 85. As far as analgesics was concerned, yes, there was a reduction of severity, but again, it lasted for a very short while. As far as placebo was concerned, obviously the analgesics were better than a placebo effect. So, therefore, the success rate which we have measured, or which the researchers have measured in these cycles, show that there is a complete or a partial relief. There's no total relief anywhere, but a significant amount of relief with the help of progesterone. Again, these are studies done a little later on, 98, 99, and here again they've got shorter studies. They've used different days of dydrogesterone. In fact, instead of using it in the beginning, they've used it from the day 16 to 25, or day 19 to 25, or even from day 5 to 25, and they found that in whatever, even if the sample size is small, they've still found that more number of patients are responding, and the ones who are non-responding probably had some other underlying problem. So again, this is another summary of efficacy studies of patients with dysmenorrhea. These were again older studies, but what we'd like to mention over here is, let's look at the advantages, not just for treatment of dysmenorrhea, but if there is an underlying endometriosis, it's helping to reduce the pain. The important thing with dydrogesterone is it does not inhibit the ovulation, doesn't affect the basal body temperature. So in those women, I mean, now we are moving a little from girls to a little older women. In those cases, again, pregnancy is possible. If you're looking at the dysmenorrhea, the visual acoustic stimulation score, again, this reduces with the use of dydrogesterone, and cyclical use of dydrogesterone probably gets the regularity of the cycle, symptomatic relief from pain, reduced blood loss, and the patient's quality of life is much more better. If you're looking at the reactive oxygen species formation, that is also much more reduced, and there is a increased production of nitric oxide. So the endometrial vasculature is also improved, and probably that's how it's used a lot in the reproductive cycles, in the IVF cycles. So when you're looking at all these, you definitely know that apart from the analgesics, Progesterones also play an important role in preventing or controlling dysmenorrhea and probably have a therapeutic role if there is an underlying endometriosis. Thank you very much.